Welcome to Women Mastering Midlife, where we dive deep into the rich complexities of womanhood in our middle years. I'm your host, Victoria Bird, a pharmacist, certified women's health coach, and your guide on this transformative journey. Whether you're navigating perimenopause, thriving in menopause, or mastering midlife's many transitions, this is your weekly dose of expert guidance, compassionate support, and a judgment-free space to explore it all. Together, we will rewrite the narrative around this remarkable stage from being something to dread into a beautiful transition. I'd like to welcome on the podcast today Vanessa Wyland. She's a board-certified adult gerontology nurse practitioner, certified clinical hypnotherapist, and Menopause Society certified practitioner. She owns Phases Clinic, a menopause clinic in Washington State where she blends hormone therapy and hypnotherapy to holistically treat perimenopause and menopause symptoms. I'm really excited to have you on the podcast today. Thank you so much for joining me.
Thanks so much for having me.
I feel like social media for me has been such a double-edged sword for a long time, but it's become a blessing where I'm making connections with women and other practitioners and just getting exposed to all the people that are out there trying to do good in the menopause space. So that's how I came across you and we connected. So it's nice to see your face and talk with you.
Yes.
Kind of it, together. So it's nice to finally get a chance to have a conversation with you about your practice and what you're doing in the menopause space. So how exactly did you get started in the menopause space?
So I finished my nurse practitioner program back in 2012, 2013. I had maybe 1 hour of menopause specific education in my curriculum. And for whatever reason, I didn't second guess that or wonder if something might be missing. And I've been practicing now for 10 years and seeing a lot of women in menopause and probably missed quite a few menopause symptoms or missed quite a few opportunities to think about vaginal estrogen in my older patients with recurrent UTIs and things like that. I've been doing home health for about 5 years now. So while I'm driving from house to house, I'll be listening to podcasts, and some of them are just for fun, but a lot of them are educational. So one of them was a medical podcast, and a menopause specialist came on, and it completely blew my mind because not only did I learn so little about menopause in my schooling, what I did learn is completely out of date, really not in line with the best evidence that we have now. And so that just lit a fire under me, one, because of that deep regret about all the women I didn't take as good care of as I could have. But also, I personally will be going through this before too long, and I was really about to be slapped upside the head with a lot of surprises. So since that time, I've probably spent 200 plus hours learning about menopause, and I feel like I've barely scratched the surface. So it's just such an insult that 1 hour is supposed to do the trick.
Oh, absolutely. I know from pharmacy school, I went to school a million years ago. I graduated in 2004. But I did graduate post WHI study, which is interesting because I had worked in a pharmacy since the age of 16. So I had been putting labels on packages of Premarin for many years. And then all of a sudden there was just hard halt of all of hormones. They collected dust on shelves for a while. And I don't think we ever discussed a patient disease state and therapeutics having menopause. I don't even think that was listed. I think it might have been on their list of medications when we would do charts and have to, just decide what to monitor and what to keep, what to take away. But it was never a discussion of why they're on it or how to, why would you prescribe it? So it's really interesting. And I think like you, it took me I was experiencing things myself and had to do my own research. And I thought there's got to be something better out there for women than just, figuring it out on their own. So I'm really glad that you decided to dive into all the hours of menopause that you have so far. And yeah, scratching the surface, it feels like the research is just scratching the surface.
Mm-hmm. Yeah, that's so true.
So when I introduced you, I mentioned hypnotherapy as a way to treat menopausal symptoms in your patients. Can you tell me about that? Because I have yet to meet a practitioner who actually uses this in their practice. So I'm interested to learn more.
Yeah, if you had told me that a year ago, I would have been surprised too. So last year, the Menopause Society put out a guideline for all the non-hormonal treatments that actually have pretty good evidence for hot flashes, because I'm sure we'll talk about more. Some people aren't great candidates for hormone therapy, or that's just not in the cards for them as a personal choice. And so They gave 5 things their level 1 stamp of approval, and that was certain antidepressants, Veoza, which is the new medication out for hot flashes, gabapentin, which is a nerve pain medicine that also helps with hot flashes. Only 2 of them were not medications. So those were cognitive behavior therapy and hypnotherapy or hypnosis. So that really surprised me too, but my first degree was in neuroscience, so it kind of tickled my brain a little bit to think about maybe coming full circle. And there have been some studies looking at how hypnotherapy can actually change brain waves and change activity in different parts of the brain. So there really is a physiologic basis for it. So I just kind of sat with it for a few months because it's kind of out of left field, but I did ultimately find a hypnotherapy training program specifically for clinicians, which is nice because I'm not starting from square one as far as building a therapeutic relationship and working with people. So I went through that program, and then I did my 20 hours of practice outside of that to get my certification. Everything I've done has been specifically working around menopause and women and gender diverse individuals, whether that's hot flashes, trouble sleeping, difficulty with this life transition, changes in like a motivation and procrastination. So it's been a lot of fun and really rewarding as well.
So how does that work as a patient? Are there a certain number of visits that this usually takes to work, or do women start to see benefits right away?
Well, as you mentioned, we have a dearth of research across the board in menopause, and this is certainly a niche. But the studies that have been done looking at hot flashes, whether someone has a history of breast cancer or not, generally find that it's about 5 or 6 sessions where there's a sustained benefit beyond 6 months. It seems to work best if the practitioner teaches the client how to do self-hypnosis and continue it on their own. That really helps to reinforce it as well. So I think there's some cases where someone might be able to make a change in just one session, but I generally tell people give it 5 sessions or so.
Well, and that's nice to know that you're offering them that as a tool in their toolbox that they could then leave working with you and still be able to do that on their own at home. Because I know that for some, it's not that easy to just pop into the clinic all the time. Or for you, the more patients you see, I'm sure being able to do this on your own and then have checkups is a lot easier for patients.
Yeah, my goal is basically to put myself out of work and then hope that word of mouth brings the next client my way. But I want to get people feeling better, not depending on me long term.
Well, and there's so much talk, I feel like, in the world out there, in the wild west of social media, that I like to call it, about hormone therapy. And there are very distinct camps of very anti-hormone therapy, very pro-hormone therapy. And there is a middle ground of, there's space for everything out there. Like, we can talk about the different aspects of hormone therapy for women and what's right for them, as long as they're given the right information. And I feel like sometimes the information that's out there isn't accurate. And we were talking about myth busting before we started recording. And what are some of the biggest hormone myths that just drive you crazy? Like, what are some things in social media that make your head scratch?
Yeah. Well, you mentioned the Women's Health Initiative. So that was a big study that came out in 2002 where they had a press release talking about how their findings went against the grain, and it showed an increased risk of heart disease and an increased risk of breast cancer. And there was this over the night pandemonium, like you mentioned, where everyone's flushing the hormones down the toilet. And that study did have some flaws. I mean, in some ways, it still is the best study we have for hormone therapy as far as how large it was and the fact that it was randomized. But they were accepting women across the board that were in menopause, whether or not they had symptoms, whether or not they were taking hormone therapy previously, and regardless of their age. So that's not really how we use hormone therapy typically. We're normally starting it when people are the most symptomatic, more or less around age 50, and then continuing it as long as they need for symptom management, and then maybe we'll come back off of it again. So when we looked at that same set of data, but restricted it to only the women 50 to 59, the script flipped again, where it turned out that there was lower risk of heart disease. And so a lot of people have really latched onto that and said, if we use hormone therapy starting from the age of menopause forward, we can probably reduce the risk of heart disease. We can't say that that's proven so far, but there's a pretty strong signal with that. So we're kind of in a funny place now where the pendulum has really swung, where for 20 years it was, all of us that were being trained as healthcare providers, it was hormone therapy is bad, end of story, offer them an antidepressant. And then now we're swinging where some people are giving the message that hormone therapy is the elixir of life and everyone needs to be on it. And if you're not, you're a fool. And that's not quite right either. I mean, maybe that will turn out to be true, but we don't have the evidence to say that confidently right now. And none of the guidelines say that we should be giving hormone therapy to everybody. So, as you say, I think the truth is somewhere in the middle. I think there's really compelling reasons to take it, but I don't think you should feel bad if you want to try to manage this without hormone therapy, particularly if your symptoms really aren't too bad.
Yeah, I think there are a lot of women who are suffering and they're
Mm-hmm.
having life debilitating symptoms. But then there are people who there was a woman I was talking to recently who was like, "Oh, I haven't had a period in a year. I guess I'm in menopause." And she didn't even recognize that anything had happened. And there is a select small few that maybe they don't have symptoms or they're not aggravating enough to cause a disturbance to recognize that there's something going on. And so I think that you are correct. There's definitely the camp like it should be in the water. And it's not necessarily the answer for everyone. And we did talk about that there are cardiovascular benefits when dosed at the right age. What are some other times that you feel that hormone therapy should be considered? And I know that it's kind of one of those things. I know there's not data or any kind of standard of care based on the research we have available yet. But what are some things that you wish you would see indicated for hormone therapy?
Well, this is an indication for hormone therapy, but it's not talked about, and that's that hormone therapy is FDA approved to prevent osteoporosis. So it's a strange number, but if you have spent most of your life below 127 pounds, I don't know where that comes from exactly. I think it's literally like the force of gravity on your bones. I don't know. But if you spend a lot of your life below 127 pounds, then you're at higher risk for osteoporosis later on. And that's even more true if you have family with osteoporosis. So let's say you're someone that's always been slender and you're not really having hot flashes, you're not really bothered by menopause symptoms, but you plug your information into a osteoporosis calculator like the FRAX, FRAX, and it says that you're high risk, then you can go request hormone therapy as a preventative, and that is an FDA approved indication. It ought to be covered by your insurance and all of that. So that's something I probably personally will pursue because I'm in that camp myself. Now, that being said, if you want to take hormone therapy mainly for your bone strength, then you kind of have to stay on it. It's like one of those few situations where if you come back off of it, we think you probably lose the benefit. The biggest myth that I see is a lot of providers telling their patients, I can't do anything for you until you stop having periods. And that's not true. If someone's having symptoms, whether they're 5 years out from menopause, 10 years out from menopause, if we can more or less rule out other causes of their symptoms like the thyroid or anemia or something else, and it really seems like it's related to estrogen or progesterone, we can start replacing those earlier on. And I think that makes the most sense of all because one, like we talked about, there's a signal that the earlier you start, the better it is for you. And two, most people have the worst symptoms of all in perimenopause. So why are we skipping that whole period and saying you have to wait until you stop menstruating? It doesn't make any sense to me.
Yeah, one of my favorite places to poll the audience has become Threads. I'm actually I just love that place. Just put something out there, ask a question and everybody goes crazy. One of the women who commented said that her doctor told her she could not get any hormones from him until she was 1 year like out of menopause. Like she had hit menopause and a full year later. And I thought, where did that math come from?
And then on the flip side, a lot of women are told, okay, I'll give you your hormones, but once you hit 60 or once you hit 65, we have to stop. And there's no there's no guidelines saying we need to stop at a certain age. There's no data that's really compelling that says we should stop after a certain number of years of treatment. So if you're still deriving benefit from it as far as symptoms, or like in the case of osteoporosis prevention, you want to keep that up, there's no reason you need to stop it at a certain age. And a really large study just came out this year, which is really helpful as far as bolstering that argument. It was looking at women on hormone therapy beyond age 65, and they looked at all of the data from Medicare. So that's a pretty large population. I think it was over 10 million women. And, they did find that it was a little bit more beneficial if it was estrogen only versus estrogen with the progestin, which we can kind of talk about. That's come up more than once with research. But they didn't find a higher risk of dementia or stroke or heart attack or some of the other concerns in either group. The only signal that was a downside was higher risk of breast cancer in the estrogen plus progestin group. So that was just another little bit of data that's helpful for that argument, saying that for most people, if they want to stay on the hormone therapy long term, they can.
Are you a woman in your early 40s or beyond feeling overwhelmed by unexpected changes? Stubborn weight gain, sleepless nights, stress, hot flashes, brain fog. Does that sound familiar? That was me just a few years ago, and I'm here to tell you that you're not alone. Millions of women face these challenges, often feeling dismissed by healthcare providers or lost in a sea of conflicting information. This is exactly where I was before I became a menopause coach. So now, I'd like to introduce you to the Women Mastering Midlife community. We're not just another support group. It's your personal arsenal of advocates, experts, and resources alongside a space to connect with women going through it with you. It's exactly the kind of community I would have loved to have when I was beginning my perimenopause journey. As a founder in our community, you'll save time with curated, research-backed solutions, gain personalized support from an experienced pharmacist and menopause coach, connect with women who truly understand your journey, learn to prioritize your health without sacrificing your busy life, and join into live conversations twice monthly or catch them on demand. Don't let midlife symptoms control your story. Join the Women Mastering Midlife community today and rediscover your energy, confidence, and joy. The link to lock in the one-time low founders rate can be found in today's show notes. Don't wait, because this is your final opportunity to join the Women Mastering Midlife community as a founder and in this enrollment period. Doors are closing at the end of today, and we want you to kick off this community with us. And that was a progestin in the study, correct? And that's not micronized progesterone. That was a synthetic.
It did look at both.
Okay.
And unfortunately, both showed that.
Okay.
You're kind of getting at a question that a lot of us have, even us menopause specialists have, which is, does it matter what form of estrogen and what form of progesterone we're using? And a lot feel that the bioidentical forms, meaning that it was made in a lab to look 100% exactly like what your body makes, is maybe accepted by the body better. Maybe it's safer in some way. Maybe it's safer in the breast. We just don't have great head-to-head studies to say one is better than the other. So I think it maybe makes intuitive sense, but we can't really clearly say that quite yet.
Okay. Let's get a little bit into vaginal estrogen, because that has been another hormone topic where you do see people saying like everyone should be on vaginal estrogen. Like every woman should get some. But there are populations who are afraid of using any form of estrogen. But you had mentioned to me that there was a study that gave a green light for breast cancer survivors to use vaginal estrogen. So could you talk a little bit on that?
Yeah, so the American College of Obstetricians and Gynecologists, much like the Menopause Society, they'll put out guidelines related to hormones and menopause care. And in 2016, they set up a guideline that if someone is a breast cancer survivor, meaning they're not in treatment currently, that they can use vaginal estrogen. It doesn't increase the risk of recurrence. They put out another guideline in 2013 saying that vaginal estrogen is no increased risk for blood clot. So if the reason you've been avoiding estrogen is a blood clot risk, that's also not a concern. So truly, vaginal estrogen is basically safe for everyone. There are some oncologists that are still wary of using it if someone's actively undergoing cancer treatment. But a lot of providers like Dr. Corinne Men, she's an OBGYN who personally has had breast cancer, do feel that vaginal estrogen is safe for those undergoing breast cancer treatment, because that can be one of the largest side effects of the treatment. So if that's going to potentially make someone not take their treatment because it's so miserable and uncomfortable, I mean, really, that's a clear cost-benefit analysis there where you should be offering relief to somebody. And there are some non-hormonal treatments for genital symptoms or urinary symptoms, but truthfully, they just don't work nearly as well. And vaginal estrogen is just so safe. So I'm almost in that camp where practically everyone should be on it. I've worked in geriatrics now for over 10 years, and I've worked in nursing homes with these elderly women who are having recurrent UTIs. And so you'll throw one antibiotic after another at it, and then they become resistant to the antibiotics to the point where 9 out of 10 antibiotics don't work on their next UTI. And it truly can be the thing that unfortunately takes their life because you're just all out of treatment options. And vaginal estrogen really can reduce the risk of recurrent UTIs. So it's a life-saving treatment. It's so safe for sexual function. It can be so important. So I'm a big fan of vaginal estrogen.
Yeah, and now the vaginal estrogen, for those who don't know what it's used for, it doesn't necessarily work for hot flashes, but it does work for the symptoms, the genitourinary syndrome of menopause or symptoms of menopause. Could you kind of talk on that a little bit?
Yeah, so as you mentioned, vaginal estrogen, they've done plenty of studies where they look at blood levels of estrogen after giving it, and there might be the tiniest little bump, particularly in the first couple weeks when the tissue is the thinnest and we're using the most. But more or less, you can just say it's not getting into the bloodstream. It's really just staying there locally. So when you are post-menopause for the remainder of your life, you're in menopause. It never goes away. And your estrogen levels and your progesterone levels are low for the rest of your life. And the tissues around your vagina, your vulva, your bladder, they're really dependent on estrogen. It helps support the structure there. And so when you lose it, the tissue becomes thin, it can tear easily, become really painful. The bladder doesn't have as much support, so you might be getting more urinary frequency, more leaking, more waking up at night to pee. So just giving that hit of estrogen right where it's needed can really reverse all of those symptoms.
Wow, there's a lot of women out there who don't want to talk about those symptoms. It's something that people might be embarrassed to share even with their physicians. And so I think having practitioners who have that population of women put that on their intake forms or their assessments that they send, we all get those emails before our annual checkups with the 75 questions on them. And not one of them is a question that you don't want to bring it up. A woman may not feel comfortable talking about it especially sometimes if it's a male physician or care provider. And so to have it on a form and just be standard of care, I think would really go a long way for a lot of women.
Yeah, in my practice, I use the menopause rating scale, and it's used in research a lot. It's a validated measurement looking at menopause symptoms, and it has sexual dysfunction on there and it has urinary complaints on there. So I'm making sure to open the door to that conversation in every patient visit. And you're right, sometimes the patient really just wants to shut that door again, and that's fine. But I've had a lot of patients that actually have had their menopause managed as far as hot flashes, and they come to me with inadequate relief. And a lot of times it's of the genitourinary symptoms.
So what makes a menopause care specialist, what makes a menopause clinic different from your OB-GYN or your general practitioner?
I mean, the main thing is, like we talked about, the fact that general practitioners mostly are not getting menopause menopause care education. And even sadly, OBGYNs often aren't getting menopause specific training. So studies have come out in the last few years showing that primary care providers that are newly out of residency, only 7% of them feel confident treating menopause. And then OBGYNs, only a third of them are getting required menopause training in their curriculum. So I think it's just very hit or miss. You might have a primary care provider that like they're right on top of it, or your OBGYN as well. And I do think this is changing too, luckily. But basically, if you have a menopause specialist, you know that this is their wheelhouse. They know all the treatment options. They're not going to leave your questions unanswered, or you can tell that the provider themselves is uncomfortable because they don't know what to say next. I think that happens a lot. So at least for me personally, if I see a patient and they have a good relationship with their primary care provider and they feel that they're open, but maybe just not super trained in menopause care, I'll say, let's find your ideal concoction together. And then more likely than not, the primary care provider would be willing to take over prescribing. So I think that's a really reasonable way to go about things.
Yeah, that's nice to have that collaborative effort with physicians and other providers. So you have a walk-in clinic in Washington. Do you also offer telehealth options, or what does your practice look like?
I have two clinics. One is in North Bend, Washington, which is just east of Seattle, and the other is in Shoreline, Washington, which is just north of Seattle. And then, yes, I also do telehealth, so I can see anyone in Washington state. I'm thinking about adding other states. It's just a little bit tricky because a lot of what I do is testosterone replacement, and testosterone and some other medications like gabapentin can be scheduled drugs, meaning that it's like on the FDA list of drugs that need a little bit more approval or privilege in order to order them. And right now, things are really relaxed with that because of COVID. But there's a law that might expire this year where that becomes a little bit more stringent again, and you might need to see people in person again. So I'm kind of like biding my time to see what happens with that. But otherwise, yes, I can see people virtually as well.
Well, that makes sense. I hope we can renew those things, because even though COVID is, not what it was in 2020, I think a lot of people have really gotten comfortable with telehealth and just the opportunity to have access to care that you may not have locally. So I hope that they pass a renewal of that one.
Yeah, I hope so too. And it's been such a boon for the people that live in rural areas and don't have easy access to specialist providers. So, yes, I really hope that they keep that, but it's looking uncertain at the moment.
Oh, well. So you just talked about testosterone therapy, and what are your thoughts on testosterone therapy for the additional hormone supplementation? Because a lot of people talk about estrogen and progesterone. We're just now, I feel like, starting to get into the testosterone conversation.
Well, testosterone has bigger risk, bigger reward, I would say. So it's not FDA approved for anything for women in the United States, but there have been a few guidelines coming out about how it can be used safely in women for low libido. That being said, it's only going to work if you have low testosterone and low libido. So we need to check the testosterone level first because it's not universally low in menopause. For some people, it stays normal or even high. So if it is low and you have low libido, it's something we can consider. Like I said, there's no FDA approved option for women. So a lot of people that want to pursue this end up going with compounding or pellets. And generally speaking, we don't love those because they just don't have the same FDA approval stringency to make sure that batch by batch is really consistent and safe. So what I usually do is I actually order the male version, and then I have to explain to take only one tiny tenth of it every day. So, I mean, on the positive, that means it's cheap because you're only using a tenth of it every day. But it's, I wish that we had a female version so we didn't have to go through all these hijinks. So I use it for libido mostly, but some people anecdotally find that it's really helpful for mood and energy and sleep and hot flashes and muscle mass, all kinds of things.
Yeah, I know some women who take it and find it to be a godsend. And then, I've heard the horror stories of some, bad experiences with pellets and things with testosterone therapy. So we definitely need a female version because it's not a male hormone. It's that's one of the misconceptions, I think.
Yeah, females actually have more testosterone than estrogen in their bodies more often than not because testosterone is used to create estrogen. And men have estrogen and progesterone as well. So they're all just hormones that we all need. And yeah, we don't need all this unnecessary labeling and gatekeeping.
Yeah. Well, and the fact that it's a controlled substance has always been interesting to me because it's not typically, you don't go to the pharmacy for your anabolic steroid use. That's, it's like maybe we should go to like a gym locker room or something if we want testosterone therapy. Oh, it's a little frustrating sometimes. So what are some things that you're seeing that you're hoping are going to be the changes? What's on the horizon for menopause care?
I think the big change that I'm seeing, actually, we were talking before we jumped on about the Menopause Society annual meeting is this week, and they sold out, which is really exciting. I think that a lot more providers have realized they're kind of being caught flat-footed on this topic and that more of their patients are coming to them looking for answers, and they're just kind of like deer in headlights moment. So, yeah, I'm really excited. I think a lot more providers are interested in educating themselves about this. I think that access is going to really improve in the next 10 years. And there's a new bill out that hasn't been signed into law yet, but hopefully, if it is, it will give us a lot more funding for menopause research, which has been so far behind, especially after that WHI study. So that's what I see on the horizon. I hope I'm not too optimistic.
No, I think that that would be amazing to be able to put some of that money toward menopause. I mean, if we're fortunate enough to reach that age in our lives, we will all experience it. So it's not a small subset of the population that needs menopause care. And I think as our generations are growing into age, there's more of us. And with the care providers shortage that we've already seen, especially since the pandemic, you know, having more providers versed and have more opportunities and more options for care and more standards that they could go by, I think that's huge. I know that there's been a little bit of a push for the FDA to remove the black box warnings on estrogen. What are your feelings on that one?
Even if we leave it alone on the oral estrogen or the transdermal estrogen, please take it off the vaginal estrogen. It really doesn't make any sense. It scares people out of their wits and totally not evidence based.
Yeah, I mean, I will say that if you actually read a package insert to pretty much anything, you could be terrified if you if you just read it hard enough and you dig deep enough into it. But I do think that that does a disservice to women, especially women who could really benefit from vaginal estrogen.
Yeah, I was recently putting together a presentation for my local library that I'm going to do later this month. And, the WHI, it did show higher risk of blood clot in all the groups. And so that's a big concern for people, particularly if they have maybe a genetic predisposition or family history of blood clot. And I think we might have kind of alluded to it earlier, but vaginal estrogen and transdermal estrogen, meaning like the patch, the cream, the gel, there's not been any evidence of a higher risk of blood clot versus your baseline. So yes, you can still get a blood clot, but it doesn't seem like it's bumping the risk up. Versus oral estrogen, that is the case because of metabolism in your liver that we don't need to get into. However, I was comparing that to risk of oral contraceptives, which there's no gatekeeping around oral contraceptives, right? We give that out like candy, and that has a very similar increased risk of blood clot. Or pregnancy is actually even 4 times higher in postpartum than oral estrogen or oral birth control pills. And who have you ever known that was discouraged from getting pregnant because their aunt had a blood clot, right? So we're just really putting fertility or parenthood on this pedestal and then saying once you're in midlife and this is your quality of life, like forget about that. Just grin and bear it.
It's an interesting viewpoint that you just gave me like a light bulb moment, because birth control pills do contain higher levels of synthetic hormones than what you're getting with hormone replacement therapy for menopause treatment. And so those have been passed out I mean, from my own experience, when I was a teenager, I had uncomfortable periods and I was put on a pill. Like it was just, that was the answer for horrible periods. And there was never a conversation of when do you need to get off of it, or, what the risks are. And I actually, when I was having my first perimenopausal symptoms, I wasn't on the pill at the time. And the answer was, well, you could just go back on birth control. And then, and I thought, well, I'm not really sure I want to have that dose of hormones right now. I'd like to do something different. And it took me finding a different care provider who specialized in menopause to agree with me that that would be an okay method of treatment for I was having debilitating hot flashes and night sweats at 43. And so I've been told I was too young, or I should just go back on birth control. And I think those are answers that women don't want to hear anymore.
Yeah. And I don't have any beef against the birth control pill. I mean, it's just like the most wonderful invention that has really allowed women to, come up in the world. Since whenever it was developed, you might know the answer to the 1950s or something. But it's not the right answer for everyone, and people also aren't counseled. I mean, like you say, we give teenagers birth control without counseling them that it might cause genitourinary symptoms, just like menopause. It might cause a lack of libido, a lot of side effects, changes in the mood. So I don't have anything against it, but we really ought to be counseling on it properly, and also not strangely saying that that is safe, but then menopause hormone therapy is dangerous. It just literally makes no sense.
Absolutely no sense. Not at all. And you're right with pregnancy. We should tell all women that it's dangerous to to have, if your cousin's sister's neighbor's friend had a blood clot, maybe you shouldn't get pregnant.
Right. Or not. We'll just across the board not tell people that their family history is the game changer one way or the other on their personal health decisions.
Yeah, I think one of the things that I've really found when talking to menopause care providers is that this is a really nuanced situation for women, and that it requires a nuanced approach, and that you take more time with your patients, and that it requires some pivoting every now and then too. I think that this is, sometimes women think they're going to walk away from their doctor's office with a prescription for estrogen and progesterone. They're going to take it. Everything's going to be amazing. They're going to be saved. Because that's also the message that we're seeing on social media from some people, that like, oh my gosh, it saved my life. You're going to have to rip my patch from my dead clutches. And that's wonderful for them. But some women, they start on it, and it's finding the right dose, finding the right method of, do I need the patch? Would the gel be better? What works for me? And have you found that with women, that are they surprised by it needing a little tweaking? It's not just a panacea. It doesn't fix everything.
Yeah, I definitely try to set that expectation from the get-go that it can take several months of tweaking, and everyone is a unique snowflake when it comes to this. Some people really can't tolerate the bioidentical progesterone or estrogen, or whatever the case might be, and they might have been really hoping for that. And so, sometimes it's having to create some disappointments, but at the same time, really treating people's symptoms the best way that we can with the least side effects. So I will say I had one patient that my standard go-to for the beginning of things, which was the 0.0375 estradiol patch and 100 milligram prometheum. And she was just like, I'm sleeping better than I have since I had kids. Like, goodbye. Primary care provider can take it from here. It's just like, okay, great. But that's definitely not the most common
Wow,
outcome.
lucky her.
I know, right?
That was not my experience. That was definitely a few months of trying to figure out what in the world was going to go on, and settling on something. And I think that's, in most cases, the way that it works for women, is that you're not going to get it right first time off the bat. So women also need to be patient, that the first time they get their prescription filled, it's not going to fix everything. It may not. You might be lucky and, walk out the door and be solved. But I think that that's one of the things that women don't understand sometimes, as well as they should be a little bit more informed about what they're expecting. So it's nice that you definitely lay the groundwork of, this is our starting point. It may not be perfect.
Yeah.
That's good.
That's one more reason that you might consider adding a menopause specialist into the mix. Even if your primary care provider is totally open to hormone therapy, they might not have gone through this like back and forth maneuver quite so often. They might kind of have like their one thing that they know. So if you kind of hit a wall there, then you might consider a menopause specialist to tweak things and then try going back.
Yeah, that's a good suggestion for women out there who are thinking about venturing into the menopause clinics. So if there was one last thing that you wanted to tell women out there who are listening to this podcast about menopause care, and the way that you want women to see this transition, what would you say to women out there?
I think that, as we talked about, the wave is changing, and we can all be part of this change. And there's a lot of resources that are available for free online, like the Menopause Society guidelines and that menopause rating scale that I mentioned that I use for my clinic visits, that you can kind of print out with you, because like we discussed earlier, sad to say, by the end of this conversation, you might already know more than your primary care provider does about hormone therapy and menopause management. So just getting that conversation started, talking to your friends about it, who's a provider that listened to you and helped you. Let's just get rid of the taboo. It's dumb. It doesn't make sense. This isn't an embarrassing time of life. It's just another natural phase. And the more that we can talk about it, the more we can learn from one another.
That's great. Yeah, we definitely need to reduce the shame and the stigmas around this conversation. And I think women if anything, being an advocate for their own health and coming prepared to their doctor's appointments, having, do some reading and find the right resources out there can really make a difference, because sometimes you don't have a lot of time with your doctor, and you don't have, if you have a 15-minute appointment and you got to get in there and you have to say, you have to know what you're going to say to them. I think it's great to come prepared. And that's a great questionnaire to pull off and fill out before, if you fill it out before you go into your doctor's office. And that way you have some groundwork that you can start from with them. And you could see a menopause specialist.
Yeah. And when you bring in your menopause rating scale and they say joint pain can't be for menopause, you can say, "Oh, really? It was question 11 on my menopause rating scale."
I think that's brilliant. Okay, well, thank you so much for coming on and talking with me. I think that you have so much information for women to be able to digest and get something from that they maybe didn't know before, or something to help validate their feelings and their symptoms and what they're experiencing. So thank you so much for talking to me today.
Thank you so much, Victoria.
Thanks so much for joining me today. We will be back next week for another episode of Women Mastering Midlife. Until then, find us on Instagram at Women Mastering Midlife or Miss Victoria Bird, and join us in the Women Mastering Midlife community to continue our discussions. You'll find links to what you've heard here today, as well as ways to connect with us in the show notes below. This podcast is intended for entertainment, educational, and informational purposes only. Please note the hosts, guests, and experts featured on this podcast are not your personal healthcare providers, life coaches, or advisors. The content should not be considered as professional, personalized medical, psychological, or prescriptive advice. This podcast is not a substitute for consulting your physician, therapist, local pharmacist, or relevant professionals to discuss your specific concerns and situation. The topics discussed should not be used as the sole basis to diagnose or treat any medical condition, make significant life changes, or make important decisions regarding your health otherwise. Women Mastering Midlife is not responsible for any undesired outcomes resulting from actions taken based on the information provided in this podcast. The views and opinions expressed are those of the host and guests only and do not represent any of those other individuals or entities. Always consult with qualified professionals before making significant changes to your health regimen, lifestyle, or medical plans.